Professor of Biostatistics and Clinical Trials of the Faculty of Mathematics and Information Science in Warsaw University in Technology. He is a long-standing collaborator with CEAUL, Center for Statistics and its Application at the University of Lisbon. He currently leads the biometrical section of the Portuguese Statistical Society, and in recent years he received funding from the British charity EME Research UK and Polish National Agency for Academic Exchange to study the role of antiviral antibodies on pathogenesis of ME and chronic fatigue syndrome. He also represents Portugal in the European network Euromine, where he integrated its executive board and in the working group dedicated to the study of ME, CFS, epidemiology all around Europe. So without further ado, Nuno, thank you very much for accepting our invitation. The floor is yours.
Thank you, Antonio. And I would like you to say good morning, everybody. And first of all, I think I have to say the same words that Antonio said. First of all, I would like to thank Joanna and her team, first of all, for organizing this wonderful event. It's a lot of effort. And of course, for inviting me to be here and share my knowledge on epidemiology of ME/CFS and long COVID. Like Antonio said, I'm a little bit like an outlier here. I'm a mathematician by training, and but I did my PhD in biomedical sciences in University of Porto. So it's nice to be back in Porto and see the city again. All right, so let's go to the science. And so today I'm going to talk about ME/CFS and long COVID. Mostly I'm going to focus on ME/CFS, and I will explain you why at the end. And mostly what I'm going to share with you is my experience as a biostatistician. So what's my perspective of the epidemiological data that is out there in the literature, okay? So the outline, like I said, I just put it, just a brief introduction on the basic epidemiological concepts, so for the guys to understand what I'm telling you on some of the slides. I'm going to then to give you some information about epidemiology, ME/CFS, and long COVID. And unfortunately, if I have time, I'll give you something about Portugal and on ME/CFS and long COVID, but only if I have time. If I don't have time, come to me if you really want to know a little bit more about Portugal, okay? So when we talk about epidemiology, there's like three words that come into my mind. So it's first of all, is prevalence, incidence, and risk factors, okay? So this is mostly what I'm going to talk about. Prevalence, it's a statistical concept, and it's a statistical concept associated with these questions. How many cases exist in a population at a given time point, okay? Incidence is another one, is actually a statistical concept related to a question is when actually you want to know how many new cases were generated per unit of time. And when I say unit of time in ME/CFS, mostly we are interested in new cases per year, okay? In the context of infectious diseases, on like outbreaks, actually sometimes it's per day, incidents per day. And the last one, the risk factors, it's related to which prior conditions predisposed to the disease onset. So, okay, so it's just to have everyone on the same wavelength. So we are going to talk mostly about these three concepts. And I also want to bring you this, this last slide on the basic concept of epidemiology, because I think this is missing from most of the literature. So when we're talking about epidemiological surveillance of any disease, we have two arms for this surveillance. One is we call passive, which is mostly the cases that you can pick up in the national health systems. So it's on the concept of official health records. And then you have the second arm that is actually on the active side, and is mostly you going to the population, you're trying to pick up the cases actively. So you do what we call survey-based studies. So let's go to epidemiology of ME/CFS. Just a quick note on the disease diagnosis. I know this is a conference specialized on this disease, but no matter what, it's better to just to put this note out there. There's no biomarker, okay? And all the diagnosis is based on a clinical diagnosis. And what we actually most for example, in the European Network for Chronic Fatigue Syndrome, the EuroMIN, we discussed what will be the most consensual case definitions for diagnosis. So we have like three criteria: 94 Cities for Disease Control criteria, which is called Fukuda or CDC criteria, the 2003 Canadian consensus criteria, and then the 2015 Institute of Medicine criteria, okay? So when you actually analyze data, you need to know which diagnostic criteria you're talking about, because they are not exactly the same, okay? What we're going to, just to put some, more details on the criteria, this 1994 is the most well-known case definition of ME/CFS, and is mostly unexplained fatigue persisting for more than 6 months, and you have to have at least 4 out of 8 core symptoms. And I put it here there. The first one is post-exertion malaise. That in the beginning, in the definition of this, of this criteria, you have this post-exertion malaise was optional, but nowadays is actually the EuroMIN considered as an obligatory symptom. Okay. So then you have tender lymph nodes, muscle pain, unrefreshing sleep, new headaches, sore throats, multi-joint swelling, joint pain, no without swelling, impaired short-term memory and concentration problems. Okay. So let's go. I'm going to divide my talk on different things. So now we're going to have what we know about passive surveillance of ME/CFS. So it's mostly on number of official cases. I searched the literature. I didn't do like a systematic review and I didn't register, but it's mostly what I found in the literature over the years. There are like 4 major studies, and you have one study come from South Korea, another one from the United States, another from England, another from Norway. They are related to different databases, and it's also important. So in South Korea is the database, let's say, of the national health system there. But for example, in United States is the Optum, so it's like a health insurance company. So it's like not exactly the whole population in the United States. England is the hospital episode statistics, so it's hospital data, so it's very specific. And then in Norway is actually close to the National Health Registry. And the time periods are different. And so the prevalence across this, so you have in South Korea, 58 cases per 100,000 individuals in the population. That's the minimum that we found in this. And the maximum is actually from England, 159 cases per 100,000 cases. And I'm just going to highlight something that is more than just this table of numbers. So it's not a coincidence that 159, the highest number of cases, is from England. And why? Because you have there long periods on the database. So they analyzed the database from 1991 to 2019. And actually, if you go back to the case criteria, the first one, the Fukuda, is from 1994. So actually, they have more cases that actually don't comply with, let's say, modern case definition of the disease. So you can have much more cases that we say may be misdiagnosed if we do it the diagnosis nowadays, okay? So the annual incidence, so in this database, they also analyze incidents. So you also have around 45 new cases per year in South Korea, and 25 cases in Norway, around that, in this period of 2008 and 2012. And then in the United States, you have annual incidence that is slightly higher, from 73 to 189. And this is something, there's some Americans here in the audience, so probably they will understand that the case definition that they use mostly there is the 2015 Institute of Medicine criteria, which is actually less restrictive than the other ones. So that's why you have more cases there. Okay, if you would do other case definition, probably you have less cases. So just want to give you this research paper from Norway. So it's the data from one of these database analysis. So they actually found out in this study period around 6,000 diagnosed patients, and you have the majority are women, so it's around 4,400 women, and in men 1,400 men. So the ratio in the official records is 1:3. So it's when you do studies, you should try to have this kind of ratios, okay? This is the annual incidence. It's nothing, very exciting, but this is just a time series of that time periods. It just fluctuates over time, but it's mostly, let's say, constant. And this is the distribution of cases per age divided by gender. And so you have men and women. And what I want to highlight here is that in both sexes, you have peaks of cases around puberty and in around early stage of career. So let's say between 30 and 35, okay? So this is, let's say, the age at risk, at the highest risk, okay? So the suggested risk, only by this analysis, these two analyses, that being a woman, so you have more women than men. Then you have the poverty and early stage of career as risk factors. And I didn't have that data here, but actually many of the cases were, let's say, generated by infections. And I put it in between brackets, viral infections, because a lot of people actually report viral. But you also can have other kinds of infections. Okay, so just for you guys, I'm taking the chance of putting all my thoughts on these slides. It's a very ambitious talk. So my limitations on this data is that first of all, you have very simple demographics like age, gender, a residential area. And this is the important stuff. The data is biased towards severe cases because this is the ones they're going to pick up in the national health systems, because the mild, moderate, then probably they will be at home. The other thing is that we don't know what kind of case definitions they apply to the patients if the countries don't have like a very strong guidelines. So you can have like sub-diagnosis to poor disease recognition by health staff and no disease diagnosis that that they apply. So we don't know what kind of like if there is a possibility of misdiagnosis in these cases. And I'm just going to show you to convince you that. So that's why I'm making the case, if you understand, I'm making the case for a construction of official guidelines for research and on the national health systems to have like a specific diagnosis, so that we know what kind of diagnosis people are applying. So the problem of misdiagnosis was illustrated in this paper published last year. It was a study conducted in California, in Kaiser Permanente, which is, I think, like a health insurance kind of like consortium. So they used the case definition of the 2015 IOM criteria. The study was not exactly to estimate prevalence or incidence, but so they went to the database and they actually searched for ME/CFS diagnosis, and I put it there, the codes, so that you can see. So it's ICD-9 and ICD-10, and these are the different codes that they used to pick up the cases. And so they actually found out there were 1,000 individuals, around 1,000 individuals with these codes. Okay, when actually they contacted the patients and they did the reanalysis. So they ask again, what kind of symptoms do they have? Did a clinical reassessment, let's say, they found that only 22% actually complied with IOM case definition. So what I'm saying is that's only 22% they comply with the recommended case definition of ME/CFS. So what about active epidemiology surveying of ME/CFS? So mostly I'm just going to go briefly about survey-based studies. And I just want to bring you this reference. Probably some of you already used it in your own papers. It's a systematic review of the prevalence of chronic fatigue. Okay, and is nowadays 259 more than 259 citations in Scopus. This is like highest papers cited in the database. And I just wanted to highlight something here that most people don't pay attention. I'm just a statistician, right? And I pick up these little things. This is inconsistency. So they search the literature, and at some point they have articles that met their inclusion criteria, and they have 46 studies. But when they analyze the data, they actually analyze with 56 data points when they actually do the pooled analysis. So it means that some studies reported prevalence of ME/CFS using these case definitions, but then they are using it in the analysis, so they are duplicating the data. Okay, so this is what people are quoting in papers. The average prevalence, all the studies that they were conducted, the average prevalence is around 1.4%. The aggregated prevalence, okay, is just divided by the prevalence divided by actually if you count all the cases and then divide by the total sample size of all the studies, this is the aggregated prevalence, so it's around 0.4%, and the prevalence estimated by meta-analysis is around 0.7%, okay? So it's around 680 cases per 1,000 individuals. Like I said, this is actually flawed for me, it's a flawed systematic review, okay? So the data has actually multiple case definitions. So you're putting things together that are probably not together. You include studies actually comprise a too long period of time. So 1990 to 2018. So the Fukuda criteria was not even, put it out there. So, and actually they include studies on that. They also included the studies that don't represent the whole population. So, for example, they had studies only in adolescents, and adolescents can have different prevalence, and also this duplicated data. So, just my convey message is that we don't know much about the prevalence, but be careful with the citation of this paper, okay? And now, just bringing back to what actually we did in Euromean, I was in the epidemiology group, and we had the mission of doing a systematic review of prevalence and incidence in studies done in Europe. So you see that this is a published paper in 2020, I think, and our citation index it's much less, so it's much less impactful. So it's only 50. But we're very much more restrictive in our analysis. So in the end, we searched the literature, and according to our inclusion criteria, using the recommended case definitions and all that stuff, randomness of surveys and all, we only had 3 studies that actually could give us some information. One of the studies, and if I must say, and if I can advertise it, was conducted by Luis Naculti, who is there. So it was done in 3 regions of England, and they used 2 case definitions, CDC Fukuda, or 94, a Canadian consensus criteria, and actually the estimated prevalence is 0.2%, and if the Canadian, which is actually more restrictive, was 0.1%, okay? Then there is another study conducted in Iceland, and the prevalence was around 1.4, okay? So for me, it's the best study conducted so far is actually done by Luis and his team, because actually what they did, it was a tremendous effort. And if you can, then you can share a little bit what they did, is that actually they review all the health records themselves. So even that they had complying of the case, they had like the record of case definitions. The diagnosis, then they review to confirm the diagnosis, not only believing that the data is telling you something. And this is, for me, the most believable estimate for prevalence so far. So it's around 0.2% for the Fukuda and 0.1% for the Canadian consensus criteria. So if you want to take it something from this my talk, this is for me the best estimates so far. So now going to epidemiology of long COVID. And I just want, if I have time, I don't know how much time. Do I have time? Okay. 10 minutes? Well, it is more than enough, huh? Quick note on diagnosis. Again, long COVID doesn't have a biomarker, so it has the same problems of ME/CFS case diagnosis. And across the countries, they have different, let's say, case definitions. Most people use the WHO definitions, where actually you need to have, and this is really important, you need to have a suspected or a confirmed COVID-19, let's say, case with some kind of like a rapid diagnostic test for detecting SARS-CoV-2 infection. Okay, so this is really important. Then you need to have people reporting symptoms after 3 months, which is not exactly the cutoff for the ME/CFS, where actually you need to have 6 months. Okay, then US, UK, other countries, they have slightly different definitions, but they more or less rely on this. So that I'm just going to bring you here a review that was published last year. And so what you can see here, I don't know, so the total prevalence was around 2%. And so this study was conducted by the Official Statistics Office in the United Kingdom, and they conducted like a survey, okay, if they had a confirmed case, if they still have symptoms after these 3 months, okay? So this is the long COVID, 2%, but you have bear in mind that the definition, when you compare ME/CFS with long COVID, ME/CFS has this time window of 6 months that you cannot have the diagnosis, but long COVID is 3 months. So by that, you're just increasing the prevalence by this amount, so, okay? Here in this plot, already you can see what's kind of like the age risk factor. So it's around, again, 30 years old, 40 years old, around that, 40. Women are a little bit more affected, but not as much as in the ME/CFS, okay? And a lot of people actually are handicapped. They stay at home, don't do anything, so, okay? Okay, so, and this August, in 2025, someone actually from Yale, a team from Yale actually conducted another systematic review and a meta-analysis, and they put it all together, which is, I think it's not right, but anyway, so they put all the literature, they screen for all the literature on long COVID, and they try to understand what was the global prevalence of long COVID, and it was around 35% among the COVID-19 cases that were detected, okay? So this is the long COVID, is the prevalence of long COVID in the population of COVID-19 cases. It's not the overall population, okay? This is first of all. Then you have, this is the variation, what you see on the rest of the plot is on the top is the global prevalence, and then on the rest is some other things like where actually you have the variation of the prevalence across different regions. Okay, so I'm not going to bother you a lot about that because I want to go, to one of my last slides. So the incidence, if you go to the incidence, this was a paper published in 2024 in Nature Medicine from the team of Eric Topol, and what they see is they had around 400 million long COVID cases. Okay, that was the global estimate. And for me, it's like you need to be very careful with putting out these numbers because we are talking about in mathematics, we're talking about extrapolation. We're not talking about interpolation, which is easier to do. Okay, so under the assumptions, a lot of set of assumptions, you can do the extrapolation, but with a caveat that is actually you don't know what's happening there. So it's around 400 million cases globally on long COVID. What about risk factors? Of course, here is a conference with medical or clinicians, you must know this, all of this. But pre-existing conditions, of course, being female, coming from a deprived background, and then in the beginning of the COVID-19, you have multiple symptoms, and so on and so forth. Okay, so what I want you to show you is this slide, and this is the most important slide of my talk. And I brought this study was conducted in Barcelona, in a small town, and they did what epidemiology should have done, which is they did active and passive surveillance. And they did it in this Consorcio Sanitario de Terrassa. If there is someone from Barcelona here, I apologize if I mispronounce this. So it's a community of 200,000 individuals in the outskirts of Barcelona. And what they did, so they went to the health records. So they had a total number of cases, 376 cases, more women than men, okay? And then when they did active surveillance, they found out more cases, okay? So the prevalence that they found in this region is around, in women, 333 per 100,000 individuals, and 160 per 1,000 men, okay? And what's the problem with this? So this is just to tell you the number of cases over time. And you don't see anything strange here. So here, this is from 2020 to 2020, and there's a drop there. Almost goes to zero. You know why? Because people stop diagnosing COVID-19 with a rapid diagnostic test. So what happens is that vanishing COVID-19 is because of this. COVID-19 disappeared, so non-COVID no longer exists. And this is mostly what I wanted to say, is that we wrote, Antonio, Jaime, João Carlos Wink, we wrote a paper on Ata Médica Portuguesa that we say that most of these diseases, ME/CFS, I would say long COVID, I'm coming from a malaria background, Ebola, dengue, they had outbreaks, and people suffer from the same things, the ME/CFS types. But because the outbreaks finished, this disease disappeared even from the global burden of disease. We had data from post-fatigue or post-Ebola fatigue syndrome in 1 year. That was in 2015. And then the next report, that disease disappeared because the Ebola outbreak disappeared. Okay? So what about Portugal? Just very briefly, again, extrapolation. So if Portugal was England, okay, this is what we get. Okay, so what we are doing is the data from England, if it will apply to Portugal, you would have 180 to 300 cases per 100,000 individuals, okay? Or 90 cases to 120 cases per 100,000 individuals if you use the Canadian consistency criteria, okay? This is like I said, if Portugal was England, okay? But then, so if you do it with the data from census, okay, you actually can calculate how many cases, really cases, you can have in Portugal. So this is a population size of around 10 million, with individuals with age greater than 9 years. So the prevalence, if you assume that the prevalence is 50, so the expected number of cases is 455, and a prevalence of 100, you can have, 50 is per 100,000, okay? Then your number of cases is 950. Finally, just very briefly, I had the luck of having a PhD student that was analyzing the database of the mortality and morbidity of the Portuguese hospitals. So I just, out of curiosity, I asked him, can you just see if you have cases of ME/CFS or ME/CFS or any other things? So ME/CFS, this is what you get. 100, this is actually mostly 100 cases per year from all of this. So this is for ME, and this is for chronic fatigue. So it's really strange because you don't have, most of the people don't have chronic fatigue. They actually have myalgic encephalomyelitis. So it means that they had an infection, so have some kind of inflammation. So what I'm going to say to you is that passive epidemiology has some problems. You only deal with official records, subdiagnosis, no control for case definitions, and all that stuff. And you have a prevalence that I think is less than 250 cases per 1,000 people. And I'll just finish this acknowledging all these people. And many of them are here in this room. And of course, I always have to say thank you, not only to Joan, but also to Ileana and Luis, that they actually, they brought me to this field. Okay, and I know I'm happy to be here, and I'm happy to answer questions if you have anyone. Otherwise, you can come to me and we can have a chat. Thank you. Yes. It's very difficult because I speak a lot. No, I'm just. Okay.
My name is Diana. I'm Portuguese, an academic and a psychologist and a patient.
Okay.
And I just want to thank you because before I got my diagnosis, I wrote you on LinkedIn. I was desperate. 3 years searching for explanations of my symptoms. Nobody could tell it. And you helped me. So thank you so much.
It's okay, thank you.
A very generous person. And also, I'd like to thank you, my doctor, the doctor that gave me the diagnosis, that is here, Doutora Patrícia Pinto. She has been doing a wonderful job. And I felt very relieved when somebody understood my symptoms. That's it. Thank you.
Okay. Thank you for the comment. I'm very grateful because I'm a mathematician and I'm helping in the clinic. But that's the beauty of, let's say, of science, is that even in our own corner, we also can help. So never forget, actually, don't be desperate, and they always can help in any other way. You always have your own expertise. Okay, thank you.